Thank you for getting all of the tech set up. Sarah, I believe we are ready to start with our work session.
Thank you, commissioners. Just for the members of the public that might be listening to this work session, this is our first hybrid in-person and Zoom meeting. And so please bear with us as we move through a number of technical challenges that I'm already anticipating. These work sessions are for informational purposes only, and no decisions are made at these meetings. The topic of this work session is mobile access, and I'm turning it over to Bob Tryansky, our Director of Behavioral Health Projects. And he will introduce the rest of our speakers. No, it's the big mic, Bob. Or you can use either. Oh, okay.
Good afternoon, commissioners. This is actually the second chapter of a presentation we started with you over a month ago. And that is the work of the Mobile Response Work Group, which is a combined work group of the Criminal Justice Coordinating Council, CJCC, and the Behavioral Health Leadership Coalition, BHLC. That work group has been meeting for over a year to come up with a proposal and plan and to look at our options at expanding mobile response in our community, which was a priority that was identified in the Proposition 1 sales tax proposition. This afternoon, last time we spoke about and looked at the plans that our work group and with the leadership of Kansas Suicide Prevention Headquarters has done to put together a proposal for a 24/7 integrated 988 crisis call center. And the next component of this is a mobile access team that would pilot beginning hopefully this fall. Burt Nash has stepped up to the plate to say that they would like to lead that effort, and the work groups has supported that. And so this is really an integrated effort between Burt Nash, Kansas Suicide Prevention Headquarters, and then supported by Heartland Radac and all of our coalition partners. So I'm going to turn the presentation over this afternoon to Stephen O'Neill, Chief Operating Officer at Burt Nash, and Aaron Newton, who's the Access Center Program Manager, and they'll kind of walk us through that. And then I think also we'll hear from Sandra Dixon at DECA about the peer support component of this plan. So Stephen and Aaron.
Yes, I am. I tested it earlier. All right, can you hear me? All right, hello commissioners. I'm Stephen O'Neill, Chief Operations Officer at Burt Nash, and this is Aaron Newton. He's the Program Manager of our Access Services, which includes all of our crisis response services. And actually, next year, Aaron will be migrating over to the new crisis center, and we'll have a leadership role there, managing the front of the house that we've talked about before the access center. So we're here today to talk about our mobile access team proposal. We were given some expectations when we were asked to do this proposal, and those expectations turned into commitments for us. And the first commitment was that we would design a mobile access team that would be available to all Douglas County residents, whether or not they were a Burt Nash client. This team is here to serve any Douglas County residents, any place that they're at. We also committed that this team would be fully integrated with the rest of our crisis continuum. This is one critically important piece, but it is not the only piece. The other pieces being the crisis center, the 24/7 crisis line staffed by our colleagues at headquarters, along with the Lawrence or LMH Health Emergency Department. We have a commitment that this program is going to be data driven and data transparent. We think what we're doing, how we're doing it, and the impact that it is having is critically important for you to know as commissioners and for this community to know as supporters and funders of this critical and life-saving service. We also committed that we would design a team that in the initial phases would be available at a minimum during the hours of 4 to midnight, Friday through Sunday. And lastly, that we would root our team in the SAMHSA best practices for mobile crisis response. So my hope, commissioners, is that you have seen this and we will reference that throughout our presentation. I'm going to turn it over to Aaron, who's going to talk both about the team and about the schedule.
Good afternoon, commissioners. Appreciate the opportunity to talk a little bit about the makeup of our team. So when we were tasked with kind of looking at what this will look like, we were looking at a program manager who will be licensed through the Kansas BSRB, and that will oversee all the clinical aspects and consultation of any crisis interactions that they have with anyone that they interact with in the community. We are wanting to hire and bring in 2 qualified behavioral health professionals who are also licensed at the highest level in the state of Kansas. So that way there is no crisis service that they cannot address in the community. We are planning on fully supporting them and as well along that crisis continuum with trying to address any substance abuse licensing or credentialing that would also support them to address any behavioral health need in the community, not just mental health. Then there's the certified peer support, which Sandra will speak with here in a little bit. Our crisis case manager will also be embedded into this team that will provide more support to the response in the community, whether that is providing some coordination of care or whether that's helping provide some de-escalation or assessment and safety planning into our community. So they will also be highly trained and throughout the skills of assessment and de-escalation. A vital proponent of this team is our van. It may sound silly, but this van will be our fully remote operation workplace that they will be in the community. Our goal is that this team will be embedded into the community and that they will respond where the need is at any given time. This van will allow them to remain in the community and not have to have a designated workstation that they have to travel back into, and that will hopefully increase the efficiency of our response times. This van will be equipped with all the gadgets that you can think of to help make this a seamless transition for our community to help meet the needs of where they're at. And then we envision that this team will also be highly integrated with the Douglas County Crisis Line, who will be dispatching the team and trying to address any mental health crises in our community. So going into the schedule now, we have reviewed several options of looking into what a schedule will look like, and we have talked to a lot of our constituents and our close partners in this process, and we have developed a schedule that will address the times where businesses are not open or services are not readily available. So we're looking at Friday, Saturday, Sunday, times where people may be experiencing a high level of vulnerability without access to resources. So we're looking at 10-hour shifts, 2 p.m. to midnight, Friday, Saturday, and Sunday. We are looking at them working 40-hour weeks. So there is 10 additional hours that we're trying to be determine where that need will be filled at. We have our initial recommendation is Thursday. So Thursday, Friday, Saturday, Sunday from 2 p.m. to midnight to fill those needs. But that is something that we are also still reviewing. The teams will respond in dyads and triads, and this is for safety purposes. We want to be trauma informed, and we want to make sure that it is a physically and emotionally safe presence, not only for our staff, but the individuals that we're responding to as well. So the dyads and triads is a critical component in responding to the need. There may be points in time where someone may respond alone. That could look like a handoff if the location is in a safe place, or if it's something that we may be familiar with. So there could be some opportunity responding individually, but for the most part, the team will be responding in dyads and triads.
I'll have my colleague Sandra come up at the end so that we don't have to shuffle back and forth too many times, but she'll speak to the role of DECA and that peer role in a little more detail. And then maybe after she does that, the three of us could stand for questions. This is a high-level snapshot of the budget. We had a target of staying under 450,000 or less. As the proposal stands today, we're right around 416,000. The vast majority of that are personnel. $250,000 in Burt Nash Center personnel and 50,000 in DECA personnel costs. That's the peer. And then we have separated out, because of the unique relationship between Burt Nash and Douglas County, the Douglas County contribution to the Burt Nash Center Health Plan. This would assume that all of those employees would take the health insurance. We have no way of knowing whether they will or not, but we assume that they will. And you can see that that is very clearly carved out as a standalone item. The other items are the mileage and the vehicle maintenance. We were really fortunate to get funding to purchase a van. So we are in the process of working on that, but we will still need to maintain it, pay for fuel, and things of that nature. And then there's technology associated both with supporting the staff and also setting up the Wi-Fi and the printer, scanner, and copier in the van. And then there's training and professional development costs. The flex funding allows this team to meet immediate needs that they see when they encounter somebody in the community. There's a lot of times where food, shelter, clothing can go a long way towards de-escalating a crisis and assuring safety and meeting a need. And we wanted to equip this team to be able to meet some of those more immediate needs. There are a couple of things on the horizon as it relates to this proposal that I think are critically important. One is the opportunity to continue to receive feedback. Tonight is a great example of an opportunity for us to take feedback, to take questions and refine and improve upon this proposal. Another next step is that in May, Burt Nash Center submitted a grant to SAMHSA in the amount of $1 million for 2 years, for a total of $2 million. And a significant component of that would be adding a second team that we could plug into this first team and again begin to add days and hours that we would be available. The other thing on the horizon is the CCBHC, or the Certified Community Behavioral Health Center. The Kansas legislature passed legislation that would bring the CCBHC model to Kansas, to all 26 mental health centers, and the governor has signed that into law. That is fundamentally going to transform Burt Nash and every other mental health center in the state. The way that it's relevant to the mobile access team, based on our understanding today, is that for our Medicaid population, we will be able to include the cost of mobile response into what's called the prospective payment model for our services. So it's going to shift us away from a fee-for-service model much more to a per person per period of time model, and that would allow us to further expand on the team. So this is really the beginning of what we hope eventually becomes a 24/7 ability to respond mobily in the community. Sandra, do you want to come up and speak to the role of the peer?
Good afternoon, Commissioners. My name is Sandra Dixon. I'm Chief Clinical Officer at DECA. We're very pleased to be part of this process. One of the growing roles for DECA in this community over the past 5 years has been using folks with lived experience in addiction, mental health, and recovery to support people who are in crisis. Currently, I think you all know that we have full-time peers embedded in the LMH Emergency Department. We're in our 4th year of that work. So being part of the mobile access team is a natural transition for us. The role of a peer in a mobile access team is really being a bridge between the professionals and the person who is in crisis. The peer's role is to join with that person using their lived experience to offer hope that the person in crisis can see an opportunity of what it might be like to engage in services or support, but also to help that person feel like they have a choice in the resolution of this crisis intervention. Oftentimes folks in particularly addiction recovery, when they are faced with folks trying to help them, feel like all control is being taken away from them. And as such, they really resist the work that's trying to happen. With a peer, their focus is really helping them make good choices about the options available to them and supporting those choices, again, being the bridge with the professional.
All right, that concludes our formal presentation. So I think now's a great time for questions and discussion.
This is Commissioner Portillo. Thank you very much for that presentation and for the overall proposal that we were able to see before this. I love the way that this is built off of the pilot and a new proposal, and really the way that this has taken so much into account from the listening session that we had about mobile response as a community. This looks like a really great model. I do have some questions about the staffing. The staffing sounds really fantastic as far as who it's going to include, but looking at some of the salaries, when we're looking at a case manager with the expectation of a bachelor's degree in qualified mental health professionals, those salaries seem to be a bit low, and I'm concerned about how that may affect burnout and turnover long-term, since we really want to develop a team that can get to know our community and be here for the long haul. But if we have high turnover, I'm concerned. Similarly with the peer navigator salary, that looks like it may take into account some of that lived experience. But how do we think that, are these sustainable positions?
Commissioner Portillo, I can't tell you how pleased I am that you have asked that question. I would agree that these salaries are low. I would also say that Burt Nash has 230 other employees that are also underpaid. And for us to bring on these 5 employees and pay them significantly more than our other staff, it creates significant problems with morale and a host of other issues. I will say, and I don't think I'm speaking out of turn here, but I know that Burt Nash and DECA over the last several years have invested significantly in our compensation of our employees. Burt Nash has over the last 4 years increased compensation by over $1 million a year to our existing staff. Recently, we did a targeted pay increase for our therapists. The salaries you're seeing are actually dramatically higher than what we were paying 4 years ago. So as concerned as you are today, I know when 4 years ago, when Patrick came to Burt Nash, since then we've really tried to increase the compensation of our employees, and it is too low. And I think we will continue to do everything we can to increase those wages. Did I?
Yeah, if I can have a couple things. So the only thing I would add to that, I mean, I agree. It's a very competitive job market for licensed staff. With our peers, one of the things we learned in our experience in the hospital is we started with peers who had full-time jobs and were doing this part-time. And that didn't work. So we made a significant shift to hiring full-time peers with all the benefits, vacation time, sick time, holiday pay. And that has proven to be very successful for us in our ability to retain peers. We currently have 2 full-time staff working at the hospital 2 to 10. So we have a bit of experience with the timing of the work. And what we budgeted for Burt Nash in this proposal was actually higher than what we pay our peers in our facilities, because the very nature of going out on call in crisis when you don't know what you're going to be walking into, we believe that's worth a bit more money. The last thing I would say about peers in particular is that the folks we hire are doing this because they are giving back to the community that helped them in their recovery. And while they want to, everyone wants to be paid more, of course, but we have created a salary track and a succession planning track that we're asking them to go back to school and get licensed. So we're trying to wrap several services and opportunities around them. So it's not just about their hourly wage, but other opportunities for them as well.
And for some of those additional opportunities, are those funded opportunities for returning to school, or is it support for?
We do
those
some
types
of that. I mean, I can't speak for Burt Nash, but within DECA, we do have scholarship programs and allow them to go to school and continue to work full time. And all of us are always looking at what are those added benefits that may not be salary that can help folks grow professionally and personally. And we want to keep them because it's too expensive when we have staff turnover.
Thank you.
This is Commissioner Reed here. I was wondering if you could speak a bit more to kind of maybe paint a picture of some hypothetical calls with the triads and the dyads. And so it seems like there's a total of 5 people on the team that you're accounting for at first. And so just wondering what kind of combination you see those teams looking like when they go out to crisis. And then I'm also curious if you can give us a sense of how will you receive dispatched calls, referrals from other, I'm wondering if it's a mixture of kind of different ways that you might receive a referral. And if you can talk a bit about how that will look and how community partners will know to leverage the mobile response team.
Sure. So I'll let Aaron offer some potential scenarios. I think, all of this is very theoretical at this point. We are envisioning that the crisis line at headquarters and the crisis center, as well as 911 dispatch, will be the mobilizing factor for this team. It's practically not very pragmatic to have 10 or 20 different entities trying to mobilize what is a very limited resource. I mean, we're talking 5 people. So I think that we will work very closely to try and figure out how best to deploy them. But again, the crisis line becomes sort of that first stop that someone may have, or 911 dispatch. One scenario, over time, a mobile team gets to know the community really well. So it could be as simple as responding to someone we know really well, say downtown, who is in acute psychiatric crisis. When we know somebody, that expands the options we have for how to respond. And in that case, we might send somebody like the case manager and the peer out. Where we would want to mobilize our licensed staff is if we don't know what we're walking into and we're dealing with folks that are in really significant psychiatric crisis and may require assessment for another option, such as the hospital or even the crisis center. But I'll let Aaron kind of walk through, since this is what he lives every day.
Great, thanks. Thanks, Stephen. And I see Monica, did you want me to pass off to you? Oh, great. Okay. Yeah, so as Stephen mentioned, we anticipate being able to dispatch if it's a dyad or triad, if it's someone we know and we're familiar with, and also responding, like if maybe this could be a supplement to a co-responder. So maybe a co-responder and a law enforcement on the scene, and maybe they've secured it and maybe need to get this person reconnected with resources, or provide some more care coordination and as Stephen mentioned, hospitalization or a higher level of care if that's needed through assessment. That could be a mobile response that officers can then now go back into the community and respond, while our mobile access team can respond to that crisis need. There's also numerous times throughout a day that we get calls from family members who are reaching out for help. Maybe they don't want the police called. Maybe there is no concerns for safety, but they want someone to come out and check on them. We want to be there for them. We want to provide that care for them. And we can do that with our licensed staff. We do want to make sure that it's a safe place for our staff to respond to, which is why it is important that we respond with a dyad or a triad. And those are some situations where we could respond to family members who don't want to have to call 911, or maybe they can't get a family or loved one to the emergency room or to another level of care. We want to be able to meet them where they're at and provide that support in that moment.
Thanks, Aaron. I just had one more follow-up question to that. So about the van, which I'm excited about, and excited about the mobility and the intention to meet people where they're at, which we know is just super crucial, both literally and figuratively, emotionally and mentally also. And so I'm just curious about, I understand it's about meeting people where they're at, no matter what in Douglas County. Is that van going, is it imagined as also a transportation tool for getting folks to hospitals outside of our county or treatment facilities? Has there been discussion about utilizing it that way? I mean, that may be take it as it comes.
So, sure, I can try to answer that, Commissioner Reed. So, today, like the Burt Nash team members, they put people in their cars all day long. They take them to the hospital, to the grocery store, all kinds of places. If we're able to, this mobile team would transport somebody if they felt like they could do it safely, and it was going to complete the intervention. They would do that. I think where we have to be thoughtful is, again, we're starting with only 5 individuals in one van. So if your van is in a hospital in Topeka and something else comes up, so that's where again the continuum is really important. And I would imagine that whoever we hire as the leader for this team is going to have to make a lot of really difficult decisions every 10 hours that they're on shift about how best to allocate the limited resources that we have. But I imagine, a huge part of community mental health is sticking them in your car and getting the job done. I mean, that's what our staff are trained to do. And that's what this team will do, especially if they can, they'll do it.
Just want to, Stephen covered that really well, and I just want to add one of the other things, the aspects of this is, again, once we get the crisis center here, we won't have to be even hopefully thinking about taking people outside of our county. They will be taken care of in our county, be assessed, and then if a decision is made, they need to go somewhere else after that, then we can work on some other transportation. But we do want this dedicated to stay within the county as much as possible. So thank you.
Commissioner Kelly, excuse me. Just a quick question about the flex funding. Have you put any thought into who reviews that? It sounds like a real need, and that makes a ton of sense, but any thought on how you review? That's a significant amount of money, and have you put any thought into that?
Yeah, so I'm sure all of our organizations manage these type of funds, and typically we would set limits on what certain levels of staff can authorize. I think we want to be flexible enough that the staff in the field feel empowered to use it to help somebody, but we're probably, not going to encourage a $20,000 expense on the first day. of the team. My guess is that that money's going to go pretty quickly. And that's probably something, we can collectively talk about and how we can leverage other funds. But we have policies on how to manage those funds and how much and for what purpose, and we would apply those to this team as well.
Okay. I'd love to hear more, maybe not at this meeting, about the CCBHC. So I don't know if that's something that, I don't know that we need another work session, but it may be good, or an email, just some more details of that to us, because that maybe the other commissioners were aware, but that wasn't something I was aware of. And it sounds like it will have a big impact on our
I
behavioral
think
health
that
work.
would be good. I think it's probably the single most significant piece of mental health legislation in decades, and is a huge celebration for our state and for our community. We're still learning about it every day, but I think that would be a really, really good idea.
And then my last question is more of an invitation, Stephen, just to talk more about salaries. I can appreciate Commissioner Portillo's question on that and the community health model. Maybe how, with things like Medicaid expansion and those kind of things, we could raise salaries if some people in some positions would make other decisions than they're making now. I just want to give you that opportunity if you want to talk about sort of the whole community mental health model. And
yeah, I think that, one of the challenges that we have is all of us are operating complex healthcare organizations. We have everything that a for-profit corporation has. We have people, we have finances, we have IT, but we're asked to get the job done. And oftentimes, 20, 30, 40% of the people that we serve are not in a position to pay us for our services. And historically, that has been taken out on our workforce. And I know all of my colleagues here, we struggle with that, but we don't think that's okay. And Medicaid expansion would allow us to compensate our staff significantly better because it increases the percentage of individuals that can pay. The other thing is that as we make these very intentional community-based decisions on a crisis center, on a mobile team, we're allocating resources. And I think we send a message to the people that do this work by how much we're willing to pay them to do it. And this is challenging work. Our staff see and hear things every day that are hard to see and hard to hear. And I think historically people say we don't go into nonprofit for the money, but our staff, they have to eat and they have to afford a place to live, and they want to send their kids to summer camp. And they want to buy decent cars. So we've been able to do things on our own to increase compensation, but there's going to come a time where we're going to hit our limit, and we're going to need to have very different conversations collectively. And it's not enough for just Burt Nash or DECA or any one of us to address this problem, because we're all hiring the same people. So if one of us starts paying dramatically more than everyone else, all we've done is shift the problem. So I guess that's what I have to say on that. But this is something that weighs on me every day. When I was in a meeting last week, and don't quote, I don't know if this number is true, but I believe it is. Our HR director told me that the cost of living for an adult with one child is almost $29 an hour in Lawrence. We don't pay that at Burt Nash, and we have a lot of single adults working for us that are trying to raise a family. So that's all I'll say. You let me do that, and I appreciate it very much. Yes.
So Stephen and I are administrators, behavioral health administrators, but we're also both social workers. And so the other advantage to having Medicaid expansion is the opportunity that individuals who we serve now, who aren't covered by Medicaid, to also have access to primary health care and dental care and other services that really support recovery. So once we have an opportunity to engage them in services and give them access to this range of whole person care that Medicaid might offer to them, their recidivism back through our system and their relapse is less likely to occur, which then puts our costs down because these folks are now actively out in the community being cared for, and most of them giving back to the community as well through their employment. So Medicaid expansion, yes, would help us tremendously in how we compensate staff, but also helps the people we serve, which then reduces our costs, which gives us more funding to support our staff.
Thank you. I appreciate you taking the time to just sort of walk us through that and your thoughts on that. I just appreciate so much the work that you all do in this space. I know you're underpaid. I know your staff is underpaid. It's not right. But it is crucial work. And I appreciate the voters of Douglas County who have said, we appreciate it so much that we want to put our sales tax dollars towards this project, and just wish it was more.
And I would add my appreciation for this community because while our staff are not compensated the way we like, this community in the context of the state, we're viewed as a very privileged community mental health center. And that is because of the people who live here, who continually support the work that we do and our staff. And we receive so much support from the county and the city, and that's what allows us to do the work we do every day. So I do want to acknowledge that even though we have work to do, there's no better place to do it in Kansas than here in Douglas County.
I think that's a really important question. And I think it's a really important question that we need to continue to talk about across our partnership and across the projects that we're doing. One of the things that I've learned by working with our partners is how essential these flex funds, these barrier reduction funds, which are built into the budgets of these projects are. And how important I think it is not to be too defined in the expectation of how those dollars are used. I think the county should be fairly confident and that those dollars are being used to do incredibly important work at moments where the funds simply do not exist, right? And so, I mean, every dollar that they're spending with those flex funds, I think, are addressing equity gaps in whole varieties of ways. I think, and we've actually asked the data sharing collaborative, like for example, with Heartland Radek and the Care Coordination Project, can we start to look at how those flex funds are being used and identify those categories so that we might be able to apply kind of some of those lenses across these projects. So I just wanted to say, I think it's an important question, and there's a lot of opportunity to learn how to put our partners in a position where they are managing those. They have the resource that they need to solve the problem, and we have a structure in place that sort of trusts the subject matter experts to solve problems that are really significant. Just one quick story I know from the Peer Fellows program, because Heartland Radek has been using these barrier reduction funds, flex funds, however you describe them. But the care coordination team had done a really good job of getting a person in the community placed in an Oxford house, and Peer was working with that individual and came to understand that they're living in an Oxford house, but they don't have any sheets and they don't have a pillow and they don't have a pillowcase. And it's Saturday afternoon. I mean, it's like those types of things, paying the application fees for IDs, mobilizing transportation when the van isn't available, right? Or the designated resource. That's the type of stuff that we're doing with those funds. And it's clearly, to me, in this role being used to solve problems.
Yeah.
Really
To clarify, my concern wasn't that we didn't need those funds. I think they're
Right.
very valuable. I just think that's a real opportunity to look at where bias may enter a system and to make sure we have a check and balance or just a review to see how, when we're giving, and I think those folks who are doing that work will make the best choices and the best intentions, but sometimes it's good to have a review process just to see how did equity play into the decisions that we made. That was really the point
Yeah.
of my,
Yeah, I just
That's
wanted to
just
respond to say,
feedback,
I think we're going to take steps moving forward to do that. And we've kind of started that with the
Great.
care coordination project.
This is Commissioner Portillo. I really appreciate that, Bob, and I appreciate the comments from Commissioner Kelly. I think the social scientist in me always wants more data. And I think from a oversight perspective, data can help us kind of expose some of those potential implicit biases or unseen biases, but data can also help us see the outcomes. And so how these flex funds are really connected to outcomes. And that helps us when it comes to future budget requests from us, but also things like grant funding and how do we show that flex funds really are important for community work and advocacy work. And when we have data to help us tell those stories, that's always a positive thing. So really
Yeah.
thinking through kind of the process for how we use these funds, but also the data on the back end of how we can then mobilize those stories for future and sustained work.
Yeah, and I think, and our partners can also speak to this, but I think one of the other things we're learning is sometimes it might make sense as this evolves to kind of have more centralized pots of dollars, so that those dollars at the end of the year, we know that those dollars have been used for those purposes when they need it. So that, Sandra's done a remarkable job with DECA at kind of making sure that the dollars are available throughout the course of the year so that we don't get into a period of time where we can't get people to social detox because we spent those dollars. I think there's opportunity through the budget process and as we move forward to kind of think about, at the county level, are we kind of placing those resources in strategic ways so that all of our partners can access them optimally.
Do we have any additional questions from commissioners?
Not from me.
Thank you.
Thank you
all.
very much for the presentation. We really appreciate it. If we don't have anything further, we will recess to our business meeting at 5:30. Thank you all.